So in part two of cardiovascular disease, in terms of cardiovascular disease treatment, I'm going to summarize here some of the basic biomedical approaches to treatment. Remember in the last videos we went over the assessment techniques, including the ASCVD risk calculator. So if you're not familiar with that, be sure you review that. And we'll talk about how we can use that to kind of determine the level of therapy we need to start patients at. And then I'll talk in the following video about specific cardiovascular medications. There's some really important classes of medications that are very commonly used, and so you need to know something about those. So here's the kind of summary of treatment approaches for cardiovascular disease. Again, it's really going to vary on the type of disease present. So if we're talking about arrhythmia versus coronary artery disease, if we're talking about secondary versus primary prevention, etc. So this is going to vary, but this is kind of a general kind of summary of the different approaches. So let's just focus in on primary and secondary prevention first for atherosclerotic cardiovascular disease. And so let me talk about primary prevention here first. So with ASCVD for primary prevention, again, these are patients that have not had a cardiovascular event before, but we're trying to reduce their risk. If they are between 40 and 70, again, some go up to 75, but 40 to 75, even 80 years of age, we can use the ASCVD 10-year risk calculator to look for the severity of their risks. We can also look for the presence of any red flags like chest pain or claudication or TIAs or something like that. Those would all be immediate, more urgent concerns. But again, these are in patients who are usually asymptomatic, and we're just doing primary prevention. We can use the ASCVD risk calculator to kind of tell us the level of therapy they're going to need, and we can then address all their risk factors like diet, exercise, smoking, alcohol, and cholesterol, blood pressure, and diabetes. Now, if you're in adjunctive care specialties like acupuncture and so forth, this would be done in conjunction with a primary care provider typically to address primary prevention. But many patients will go, for example, to an acupuncturist without any primary care providers. And if they want the acupuncturist to kind of manage their general health, then it's important for that acupuncturist to know, when do I need to really refer to another physician for additional assistance here, where they can maybe get additional level of therapy and so forth. So I'll talk about that here as we go. Secondary prevention would be patients who have already had a cardiovascular event, and generally we need to start at a higher level of therapy. So we're going to start at the so-called level 4 therapies, which address pathogenesis, and I'll summarize those here in just a minute. Again, we're going to look for red flags. We're going to probably in this case need a PCP at least, and maybe even specialists involved in that patient's care. And then we can help address the ASCVD risk factors. There are different guidelines for management for cholesterol, for hypertension, diabetes, and the need for anticoagulation. And I'm going to kind of summarize some of those guidelines as we go, but they're all available out there for free online through the different organizations like the American Heart Association and so forth. So for our 4 levels of the therapeutic order, remember, level 1 is really establishing the conditions for health. So that would include our diet recommendations, and I'll review those here in a moment. Our exercise recommendations, lifestyle recommendations, and stress reduction. So, I don't think anyone's going to argue that this is a good foundation for health in general. Level 2, and I'm going to include 3 in here, would be supporting salutogenesis. Those are, supporting the natural physiologic, the healing mechanisms of the body. And so that would be essentially doing, in Chinese medicine, for instance, our pattern differentiation, which is essentially the same thing as saying we're working with the neuroendocrine system, and then working through all that. Giving specific support, for example, mitochondrial support for cardiac muscle. And then if any hormone replacement like thyroid replacement is indicated, that would fall into this category as well. But level 4 would be the typical biomedical approaches, addressing pathogenesis specifically. So addressing inflammation, addressing blood pressure, diabetes, anything that has an anti before the name, an antihypertensive, anti-diabetic, etc. This would be level 4 therapy. Our classic cardiovascular agents, which we'll go over in the next video, would include things like beta blockers, ACE inhibitors, and angiotensin receptor blockers, calcium channel blockers, diuretics, digitalis, vasodilators, nitrates, sodium channel blockers, which are also known as class 1 antiarrhythmics, and potassium channel blockers, class 3 antiarrhythmics. That pretty much summarizes it. You know, throw in antibiotics and steroids for vasculitis and whatnot. That pretty much summarizes it for the majority of the biomedical agents used in cardiovascular diseases of all kinds. Other modalities would be things like implantable defibrillators. So some patients with very low ejection fraction, below 35%, usually due to an arrhythmia, will need a defibrillator. But that is implanted, and it will, whenever it detects the fall in cardiac output or it detects an abnormal heart rhythm, it's going to shock the patient and reestablish the normal electrical rhythm. There is cardiac contractility modulation, which is other electrical techniques to stimulate the heart. Ventricular assist devices, cardiac resynchronization therapy, again electrical, trying to reestablish a normal heart rhythm. We have heart transplant, which I'll talk about later, and then palliative care for patients with end-stage heart failure who maybe are not candidates or not able to get a heart transplant. These would all be other modalities used in biomedicine for cardiovascular diseases. So that's a summary of all the different approaches. Now let's dive into each of these and look at them in more detail. So in the last video, I talked about level 4 therapies, and one therapy I didn't include in there, which, you know, I think it probably should be, it's a major class of cardiovascular medications, would be the cholesterol-lowering medications, and specifically the statin medications. So we'll talk about statins as a class here coming up in the next video. But the question is, when do people need statin medications? You know, so everyone with high cholesterol doesn't need these drugs. And so I want to just give you the guidelines that are currently being used so that you know something about that. So these guidelines are based on the American Heart Association, American College of Cardiology, using the ASCVD risk calculator that we talked about in the previous videos. And this estimates your 10-year risk of cardiovascular disease. It gives you a percentage. And remember that low risk is under 5%, intermediate 5, really up to 7.5, and then high intermediate going up to 20%, and then very high over 20%. So the statin guidelines are kind of based on, number one, age, but also your ASCVD risk. And we're talking about, again, primary prevention. I'll just say that in terms of secondary prevention, so if a person has already had an atherosclerotic cardiovascular event like a stroke or an MI, the current recommendations are everyone needs a statin, unless they can't tolerate it. So secondary prevention is easier. Usually everyone is triaged to a statin, versus with primary prevention, it's a little bit more nuanced. So first of all, let me just talk about the different classes of statins, and then we'll go forward. So again, what is a statin? Very quickly, it's a drug that blocks the production of cholesterol in the liver. And I'll talk later about all the other potential adverse effects it has, because it doesn't just do that. But let's just focus here on the different types of statins. We classify them as either high intensity, moderate intensity, or low intensity. And some common agents, these references refer to how much they lower LDL. So the high intensity lowers LDL by 50%, medium intensity 30 to 49%, and low intensity less than 30%. Now I should tell you that diet and exercise, just going back to that, and that's why that's on our level 1 therapies here, diet and exercise actually seems to lower cholesterol somewhere between 35-45%. So that's a pretty significant reduction of cholesterol. So that should always be implemented first. As you will see, working with clients, it's not always that easy, and many patients just don't want to or don't have the motivation to, so we have to do all we can to help protect them further, and that's where we might need to jump into these therapies. Other patients have already done the diet and exercise, and they still need cholesterol lowering, and that's where these would be initiated. Some common agents would be like atorvastatin, which is Lipitor, and rosuvastatin, Zocor. And so this is using them at their higher dosage ranges, 40 to 80 milligrams and 20 to 40 milligrams. Versus, atorvastatin 10 to 20, rosuvastatin 5 to 10 would be more moderate intensity statins, and then so forth. Usually we don't use the low intensity statins except in patients who can't tolerate the higher levels of statin. So let's look at who needs the statin. So again, for primary prevention between the ages of 40 to 75, an ASCVD risk of less than 5%, we really don't need statins. So that's lifestyle modification only. If a person's ASCVD risk is between 5 and 7.5%, we consider a medium intensity statin or moderate intensity statin if their LDL is over 160, if they have a family of history of early atherosclerotic cardiovascular disease, and that would be in males. So having a father who had a heart attack before 55, or a mother that had a heart attack before 65. Having the presence of chronic kidney disease, metabolic syndrome, which is pre-diabetes, hypertension, obesity, and the high triglycerides and low HDL. Triglycerides over 175, an elevated hsCRP, an elevated Lp(a), ApoB. Again, this is where some of these other biomarkers can be helpful. Coronary artery calcium score of greater than 75%, or the Agatston score of over 300, an ancobrachial index of less than 0.9, and the presence of chronic inflammation like from autoimmune disease or HIV. All of these would tell us if a person between 40 and 75 had the ASCVD risk between 5 and 7.5, we would consider a medium intensity statin. With an ASCVD risk of 7.5 to 15%, that's when usually a medium to high intensity statin is considered. Greater than 15%, that's when it's kind of like, okay, start the statin. And then if a person has diabetes in that age group, and their ASCVD risk is over 7.5%, then we consider the high intensity statin. If they're diabetic and their LDL is under 190, then the high intensity statin is initiated. If it's over 190, then we do the high intensity statin. So those are just, I know that's a lot of little details, but to give you a feel for like which patients are going to receive statin therapy, that's what the current guidelines are kind of indicating. So that's one risk factor, is cholesterol. Another risk factor is hypertension, and I'll just quickly summarize that. We'll have a whole video on hypertension. But basically, the guidelines here are that lifestyle recommendation is for everyone. But patients with an elevated blood pressure, that would be a systolic pressure of between 120 and 129 millimeters of mercury, and a diastolic under 80. Usually, if their ASCVD risk is either 10% or under 10% or over 10%, medication is usually not recommended unless the patient's diabetic and their ASCVD risk is over 7.5%. If they have what's called stage 1 hypertension, that's a systolic pressure of 130 to 139, diastolic 80 to 89. Medication is recommended in patients only with an ASCVD risk of over 10, or if they're diabetic again. And then stage 2 hypertension, that's a systolic pressure over 140, diastolic over 90. Medication is recommended there in all classes. So that's for hypertension. And then finally for antithrombotic protection, that's where aspirin is sometimes recommended. And the current guidelines for primary prevention are kind of like, we probably shouldn't be using aspirin. The risks actually outweigh the benefits. So that's something you should know in those patients of yours taking aspirin for primary prevention. It is still recommended in patients between 50 and 60 if their ASCVD risk is more than 10%. Unclear benefit in those between 60 and 69, so there's a big question mark. And then not recommended for patients under 50 or over 70. Again, this is for primary prevention. It's going to be different for secondary if you've already had an MI or stroke or another event. So I know it's a lot of details, but that sort of summarizes the basic treatment recommendations that are currently out there for risk reduction, looking at cholesterol, hypertension, and antiplatelet agents for CVD treatment. I'll say one more thing about cholesterol, in that most patients, the LDL targets are that LDL should be less than 100 milligrams per deciliter, except in patients with a known ASCVD history. In other words, they had an MI, or they have heart valve problems, etc. They had a stroke, or they have diabetes. Then their LDL, the recommendations are under 70. So you might see patients coming in being told that their doctor wants their LDL under 70, and that's probably why that's the case. Okay, so that summarizes it. We'll see this again and again as we go through the different cardiovascular conditions. I put these tables here from the American College of Cardiology and American Heart Association for your reference, but this would be again for primary, and the second table below is for secondary prevention, ASCVD risk, and so we can use our calculator here to determine our risk for our different patients. And so this summarizes kind of what I just said in the last video. So I won't go through all that. Again, the recommendations for secondary prevention are pretty much everyone receive a statin therapy, unless, depending on their age and other factors here. But usually statins are recommended for those groups. So I'll let you read through that. Now, going back to a therapeutic order, again, we want to not just look at cholesterol and those kinds of things. We want to look at the whole picture, and how do we really address all the risk factors. Interestingly, the American Heart Association does have a very strong stance on this, and they're like, yes, this is probably the foundation of preventing cardiovascular disease, is working with our diet, exercise, lifestyle recommendations. Now, these factors, these recommendations are applicable not just to atherosclerotic cardiovascular disease, but also diabetes, metabolic syndrome, and then heart failure. So all of these these risk factors are the same, and so our recommendations would be the same. So in terms of diet, the basic diets we know, there's a couple that are out there that are well studied for CVD prevention, and that is the DASH diet. That's specific for hypertension. So that's dietary interventions to stop hypertension. And then the Mediterranean diet. So those have received the most research. Now there's many others. A lot of the newer diets, like ketogenic diets and what, we just don't have enough data yet on whether or not they're actually going to decrease the incidence of heart disease, decrease mortality from heart disease, and so forth. But that might be coming down the road. We do know out of all these, probably the most significant factor is calorie moderation. So there's been an increased interest in intermittent fasting and whatnot, and I think it's really something to consider. I use that a fair amount with my patients, and it's been very helpful for many of them. We do know that decreasing processed foods, sweetened beverages and sodas, decreasing salt intake to less than 2,400 milligrams a day, but some give the estimate of 2,000, decreasing saturated and trans fat intake, decreasing sugars, calories, and caffeine. All of these are important. Some argue that also decreasing what are called high lectin foods might be protective in heart disease, and that would include a lot of your nightshades or things like tomatoes, also different legumes like red kidney beans, soybeans, wheat, peanuts, potatoes. These lectins can basically create systemic inflammation, and so a couple of cardiologists out there are like, stop all your tomatoes and lectins and whatnot. I don't know of any clear data on that. I know anecdotally some people claim that that's helped them lose weight, but it's probably they're doing calorie restriction as well in those cases. We do know increasing vegetables and fruits, legumes for the most part, nuts and seeds, flaxseed, olive oil, fish at least twice a week, and that would be tuna, salmon, mackerel, trout, herring, sardines. These all have the good essential fatty acids. Notice that a lot of the bottom fish are not included there, shellfish and whatnot. They have, unfortunately, other issues. And we usually limit it to twice a week because of the potential, even in these fish, of mercury poisoning and accumulation. If you eat it less than no more than 2 times a week, then your chance of that occurring is a lot less. So we're more concerned about that in young children than in adults. And then increasing whole grains as part of the Mediterranean diet, but that would be going outside of just wheat, looking at oats and brown rice and so forth. So those would be the typical diet recommendations we do know about. I didn't put eggs on there. Eggs are a little controversial in terms of cholesterol. It turns out the lectins in eggs actually are very helpful to form new bile, and that can actually get cholesterol out of the body. So eggs, are one of those kind of things I do recommend in moderation for patients, but we kind of watch their cholesterol levels. Same thing with butter. Butter has all sorts, especially ghee, and the natural butter is loaded with all sorts of good fat-soluble vitamins. And so some of those, like one very important vitamin I haven't discussed for blood vessel walls, is vitamin K2. In fact, this is a real issue with calcium. So calcium, when it gets into the blood, we actually want it to go to the bone. Vitamin D helps us absorb calcium, but the vitamin that helps get calcium into bone is K2. And one concern is if you have low K2 and high calcium vitamin D, all that calcium is not going to go into the bone, but into your blood vessel walls. It's going to calcify any plaques and whatnot, and that's what we don't want. So some people have argued that atherosclerosis is partly a vitamin K2 deficiency problem. K2 only comes from meats and especially things like butter and ghee and so forth. And so if you cut those things out of the diet, we're now losing that nutrient, and that might actually accelerate atherosclerosis. So that's why I think there is still interest in those good foods being added to the diet. Exercise, we do know that moderate exercise defined as 30 minutes a day or 30 minutes at least 5 times a week. Vigorous is 20 minutes 3 times a week. Both mixture of aerobic and anaerobic is very important. And then interval training here might also be an important feature there. And then lifestyle interventions, decrease alcohol intake for males. That's 2 drinks a day or less. Females, 1 drink a day or less. Decreasing or stopping tobacco smoking. And then sleep hygiene, getting proper sleep, good 8 hours with good melatonin. And then weight control, usually through calorie restriction. And then stress reduction with meditation, yoga, qigong, tai chi, etc. All of these would be part of our level 1 foundational therapies, and a lot of good evidence for all of them really in helping to protect against cardiovascular disease, but also treat patients with known cardiovascular disease. Now I'll end this video on Chinese medicine patterns, so level 2 therapies supporting salutogenesis. And then I will discuss the level 4 therapies in the next video here. But if we look at our Chinese medicine patterns for heart disease, and this would include atherosclerotic cardiovascular disease, but also all the others, we of course look at heart yang, qi, blood, and yin, either deficiency or excess states. So we'll start with the yang states. A heart yang deficiency is described in the literature as having edema, cyanosis, poor circulation. This is the classic finding in heart failure. So a lot of our inotropic agents that increase heart muscle contractility and whatnot, herbally could be potential uses here. Many of them are classified as heart yang tonics. Heart fire blazing would be more of a inflammatory process, which we might see in vasculitis and pericarditis, myocarditis, endocarditis, and severe hypertension. Remember, when we say heart in Chinese medicine, we're referring to the heart and all the blood vessels together. So this includes the vascular diseases as well. Going to qi disorders, these would be problems of the autonomic system. So this would include a lot of our arrhythmias. So things like palpitations, bradyarrhythmias would be more qi deficiency, and that would include heart block as well, maybe in heart failure. And then heart qi constriction would be more excess activity, sympathetic excess, more tachyarrhythmias, and we'll look at all those like premature atrial contractions, premature ventricular contractions, supraventricular tachycardias, and atrial flutter, atrial fib. Heart blood deficiency would essentially be more of an anemic state. So you might think of that as more anemia. And then a heart blood stasis would be the pattern I talked about, having increased thrombosis and endothelial dysfunction. So this would be our classic atherosclerotic coronary cardiovascular disease risk. So increase in the risk of coronary artery disease, peripheral artery disease, and cerebral vascular accident. So that's blood stasis, and we see that also in hypertension and in diabetes. So this is a very important pattern to address. Heart yin deficiency, we might find that in menopausal states. Think of that as a low estrogen state. And that can also contribute to hypertension because estrogen helps arterioles vasodilate. So when there's inadequate estrogen, they can get more vasoconstricted. And then yin excess, we can think of that as a phlegm state. We might think of that as more patients with more insulin resistance, type 2 diabetes, and increasing incidence of stroke and hypertension, etc. Now, those are the patterns in your Chinese medicine training. If you're in the Chinese medicine program, you can now connect different herbal therapies and different acupuncture regimens with each of these patterns. So I won't go over those here, but that at least would open up the ability to more finely differentiate your patients with heart disease and what kinds of herbal treatments they might need specifically. So that wraps it up for level 1, level 2, and 3 therapies. And the next video, I'll look at level 4 therapies and a summary of all the biomedical cardiovascular medications.